you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He's slightly intoxicated. Got his wrist pain by doing over-aggressive high fives to his buddies.
Hey everyone, welcome back to the Ultrasound Podcast. We're going to do something a little different this month. We're going to talk about lung ultrasound. Now, I know what you're saying out there. You're saying, Malin, you just did that last summer, and I've already watched it like 14 times, and Dr. Noble's the bomb. Well, I know, but we couldn't pass this up. See, a funny thing happened in Denver last October. Man, myth, legend, none other than Mike Stone gave a talk at ACEP, and it wasn't about nerves. Shocking, I know. Turns out Lord Bundle knows a thing or two about the alveoli, too. And this is another growing area of ultrasound, and definitely an advanced skill, but possibly one of the most practice-changing in my mind. Think of all the radiation we could save if we just replaced every chest x-ray with ultrasound. Now, I've done the math, and if you assume an average of 6 chest x-rays per person per lifetime, and 4.5 billion people in the world, that ends up being about 17 kajillion millisieverts of radiation. In fact, more radiation than the sun. But I can't give up my chest x-ray, you say. Well, what if I told you the literature supports ultrasound as a more accurate tool than chest x-ray for virtually every diagnosis? Pneumonia, heart failure, bronchitis, pericardial effusion, pneumothorax, rib fracture, the list goes on and on. But don't take my word for it. Let's hear from Lord Bundle.
So almost 8 years ago, I became convinced that I should start using lung sonography to assess critically ill patients. And I was a new attending. I'd already racked up an M&M or two. And I had the paramedics bring back about a 60-year-old guy with bad COPD. And, he was speaking one-word sentences. This feels like my COPD.
I can't understand you. Yes, this audio quality isn't the greatest. We know. We thought about asking Stone to re-record this in front of a microphone, but then you wouldn't get that energy that comes from a live show. And how else would you know he's telling a joke without hearing the audience laugh? I mean, there were 3 or 4 times during this talk that I had no idea it was a joke until I heard the audience. So, we left those clues in for you. Man, this guy's gonna hate me.
And tachy to 130, hypoxic to 80 on room air and 88 on the face mask, tachypnic into the 40s, hypotensive, not moving any air with no breath sounds on either side. Sort of a great 3 a.m. adrenaline surge wake-up call. And I called for a stat portable chest with our resident who was assessing him. He was getting put on the monitor and access and everything. And the tech was nowhere to be found. It turns out he was in the ICU doing films for the morning, and we had no chest x-ray. I'd heard about lung sonography. We took a look at his lungs. His left side looked like it was okay. His right side looked like the pleural wasn't really moving and the lung wasn't sliding. I'd heard that might mean there was a pneumothorax, but I'd never done it before or seen it before. And we decided, well, he was going to get intubated and he didn't have any movement on the right side, so let's just see what happens if we vent the right side of the chest. And resident went ahead and prepped him up quickly, popped into the right side of the chest, and we got this huge rush of air. And I felt like amazing, right? And then this huge stench filled the air. And it was just awful. I mean, just combine the worst smells you've ever smelled in emergency medicine. It was like socks mixed with perianal abscess. I mean, it was just awful. And the surgeons, 3 surgeons swarmed into the room because they smelled it. And it was some orbitofrontal cortex hypothalamic reaction. They're like, that's a surgical problem. And they ran into the room, and right as she put the chest tube in and drained 1,800 cc's of pus. And this guy had enormous pneumothorax from an anaerobic empyema. And immediately, vital signs stabilized, diaphoresis dried off, got admitted, had a complex course, did well. But probably would have been intubated if we didn't have the ability to do lung sonography, and could have definitely decompensated even worse with his tension physiology that he had. So, ACEP likes catchy titles like pulmonary ultrasound. Who needs a chest x-ray? You're going to get a chest x-ray in a lot of your patients because we don't operate in a vacuum, and your consultants are going to want it. There's reasons to get chest x-rays. But I think maybe a better topic for this talk or title would be how to make critical decisions in the chest without guessing. And we're 80%ers in the ER, right? We're right a lot of the time. But anything we can use at the bedside with limited information that we have to make us better, I think is something worth doing. So in the next 50 minutes, I'm going to try and introduce you guys to lung sonography and see if we can't make some progress. We'll talk about principles and language, the technique that you need to know, some clinical scenarios you'll encounter. We will not cover basic ultrasound physics. I know you're all really disappointed. machine purchasing, billing. We're not getting into any of that. This is how to use lung ultrasound and incorporate it into your clinical practice to make better and more accurate and more rapid decisions and provide better patient care. So this is, apple pie of medicine, right? The chest x-ray is just, you don't get more medicine than that, okay? But if you're looking for an opponent, as my friend Vicky Noble likes to say, to promote ultrasound, the plain supine chest x-ray is about as best as you can get because it's really horribly inaccurate for most things. It's really good for big picture stuff, but it's not a perfect test. What it does do that ultrasound doesn't do is it gives you one click, no provider time, big picture of the chest. If you want to see all of this, ribs, mediastinum, heart, lungs, pleura, pleural cavities, diaphragms, shoulders, clavicles, you can see all that with ultrasound, often with a lot more detail and a lot more accuracy, but that means you're running the probe over every single part of the chest, and we're not going to do that. Okay, so I'm not here to say don't do a chest x-ray, but I'm here to say in specific clinical scenarios and instances, that's not the first test, and you may not even look at the chest x-ray once it comes back for your consultants because you already know the answer. All right, this is a study out of chest about 1.5 years ago. Can chest ultrasonography replace standard chest radiography for acutely dyspneic patients? And these are the things we worry about, right? There's pleural effusions and pulmonary edema, pneumothoraces, pneumonias. I'm not going to run through the evidence base for all of this, but ultrasound is more accurate than chest x-ray for every single one of these things. And we're getting a growing body of literature that it is a way better initial test for the acutely dyspneic patient than chest radiography. Lung sonography is different. If anybody here has not done any ultrasound, this may be tough, this talk. If you've done some ultrasound, you realize that most ultrasound kind of looks like what you'd expect it to look like. There's a CT scan of the heart on the left and an ultrasound on the right. And tissue looks like tissue, chambers look like chambers, and this is kind of familiar stuff. It looks like another representation, maybe it reminds you of gross anatomy lab. Lung's different, right? There's a lung that's got some pulmonary edema, a little bit of tree and bud stuff, some interstitial thickening. When you look at the chest wall, it looks like this. And that doesn't look anything like the thing on the left. Lung sonography is about interpreting the artifacts that arise from the pleural line as the sound wave crosses into the chest and scatters differently depending on what's going on in the chest. It's artifact analysis. It's not a true representation of the tissue underneath. Everything under this line that's moving back and forth here, which we'll pay a lot of time talking about, everything deep to that, it's not real.
Is this real life?
It's not real tissue. There's certain circumstances where the lung becomes solid, like consolidation or huge effusions where the lungs has enough atelectasis where it looks like tissue, but most of the time you're interpreting artifacts, so it's different. Lung sonography is actually more like an EKG.
You mean like an EKG except sensitive for pathology? Please, no hate mail. Or if you must, please send to mike@ultrasoundpodcast.com.
If you took a look at an EKG, that doesn't look like a heart, but it tells you a lot about what's going on in the heart. And lung sonography is very much the same way. I look at the right side of that screen, and it's not moving because it's a still image, but I can tell you that patient doesn't have pulmonary edema. And just with that image, you can get a lot of information about the chest without having to interpret it sort of so literally. So transducers and technique. There's a lot of controversy about which transducers you can use to look at the chest. I think that it's very overblown. Okay, you can use a curvilinear low-frequency transducer like the one on the left, an abdominal probe. You can use a high-frequency linear transducer, the vascular or small parts probe on the right. People have done this traditionally with the initial literature with a microconvex low-frequency transducer, so the really small, tightly curved probe. People have used there's some good emerging evidence with the phased array or the cardiac probe. I prefer a low-frequency probe for looking at everything in the chest, with the exception of lung sliding, which if you're having a hard time, the high-frequency probe can help. Okay, so that's my own personal preference. There's no evidence base for any of this. So use the transducers you have on your system. Don't let anyone tell you you can't do a lung ultrasound with that kind of probe, because there's really nothing to back that up. The technique itself, lung sonography is also different in how you do scans. So if you've done like a fast exam or an echo, somebody told you to put the probe in the right place on the body and fan through and make sure you're seeing every little section of that part of the body and interrogate the space thoroughly and make sure you get down to the inferior pole of the kidney and there's no fluid in the paracolic gutter and look all over. Lung ultrasound is totally different. You take the transducer and you put it on the chest. It should be sagittal, okay? So it should be vertically oriented on the chest. You want it to be, in a supine patient, to start off right in the front, in the midline, and you want to be around the second or third intercostal space, so you're up around the sort of ceiling portion of the chest. If you have a pneumothorax, it's going to rise to the top, and that's where you're going to see it in a supine patient. Okay? Now, what you do with it that's different is you do angle back and forth like the bottom pictures there, but you do it until you get a nice perpendicular view of the chest. And then you stop, and you watch. And you're looking for lung sliding. You're looking for two different patterns we're going to talk about in the chest. But you don't, once you find that view, you stop and you observe. And it takes you 3 seconds to observe what you want to observe for, but you don't go fanning back and forth. Once you get that view, you sit and you wait. And that's different from other ultrasound exams. Now, location, there's about 15 different groups between the US, Italy, and France that'll tell you the exact locations that you need to ultrasound on the chest if you want to do a good exam. And none of this is evidence-based either. But in a supine trauma patient, you want to look here, and you want to look here, okay? Air is going to rise up to the top. You're looking for a pneumothorax. If you want to look for pleural fluid, pleural effusions, you want to look down here, just above the diaphragms, just like you're doing a fast exam, except tilting into the chest, okay? Now, if you look in additional places and over the chest like that, slide down over the chest like here, you'll get more information about each lung side. But for the most part, in an acutely ill, dyspneic, hemodynamically unstable, or poorly oxygenating or ventilating patient, if you look anteriorly at the yellow X's and down at the red X's, that's plenty of information. You'll get everything you need to see. Okay? You got to be careful over here because there's something that sits in the chest there. I think you guys have heard of it. And it can confuse people. So make sure that you know where the heart is and you steer clear of it. The only other thing I'm going to talk about with technique is that you need to stay perpendicular to the thorax. So as you get out laterally, remember the thorax is curved. And as you get out there perpendicularly, you're going to need to tilt your probe so you're getting a perpendicular view. Okay, so as you kind of slide off the chest laterally, you do have to tilt your probe to stay perpendicular. You also want to take your ultrasound system and dumb it down. And if you don't know how to do this, it's totally fine. You got to get your clinical applications person. Every single ultrasound system that's in your ED is made by a vendor. Every vendor has a local clinical applications person. You can Google the name of the vendor and call them and say, hey, I'm at this hospital. I need to know who the person is who supports my ultrasound system in the ER. They will come to your ER and they'll pre-program your machine with a lung preset. Lots of ultrasound is built upon reducing artifacts, right? We want to picture the liver. We want it to look as pretty as possible. There's a lot of software stuff on the back end that you don't see that goes into reducing artifacts and speckling and compounding and stuff you don't care about that makes it look prettier. You want a machine that doesn't do that so you can interpret these artifacts. And if you look up here, everybody sees there's these bright vertical white lines on the right side of the screen that are kind of moving back and forth. You don't see them as well on the left. This is the exact same patient with pulmonary edema at the exact same time. If you could look and interpret those tiny little marks up here, you would see that some of the software stuff and processing has been changed. It's the only thing that's different. And they can do this pre-programmed for you so you don't have to go in and change all this stuff and know how to do it. But you can have something that doesn't reduce artifact and gives you a clearer picture of the artifacts that are arising in the lung. And it's a little thing, but it'll actually help you quite a bit. All right, this is what we need to talk about to start. This is your home base when you're doing lung ultrasound. And you're going to see rib and rib. That's what you want to see to start with. You're also going to see shadowing deep to the ribs. Okay, that tells you that you're looking at the ribs because bones shadow, the ultrasound doesn't penetrate through the bone. The bright surface in the near field reflects the ultrasound back and everything else is dark deep to it. Then the bright horizontal line running just underneath the ribs is the pleural line. Okay, ultrasound's good, but it doesn't show you visceral versus parietal pleura. You just see the two of them stuck together at the pleural line. It's a bright hyperechoic line just deep to the ribs. Everything in the near field there above the ribs, that's all soft tissue and muscle and pec and intercostal muscles. Everything deep to the ribs and deep to the pleural line is artifact. Okay, so this is what we're looking for. This is sort of our home base view of what we want to see when we look at the chest. Now, when you look at the chest in a patient who's breathing and doesn't have a pneumothorax, it's going to look like that. And everybody sees that the bright line there, that pleural line, oscillates left and right and slides. That's lung sliding. Okay? If we all took an ultrasound right now, put it onto our own chests, none of us that had pleurodesis or a pneumonectomy, we would all have this. Okay? This is, if we're going to make the analogy, that's the bat sign. They'll talk about a bat sign. I have a hard time seeing it unless the bat's actually superimposed on the image. So in case you read about it, that's what they're talking about, but I have a hard time seeing that. Ultrasonographers were like cloud watchers. We like to see images and shapes. But lung sliding is like the sinus rhythm of lung ultrasound. You know, if somebody hands you an EKG and you're working clinically and it's non-sinus, you get this negative dopamine feedback loop and you kind of, something stops it, you feel bad inside, you look at it and you go, something wrong here. Okay, that should be the same thing when you look at a lung ultrasound and the lung is not sliding. Something should just make you feel like something is wrong and I need to go look at this patient. Okay, the one on the left, sliding or not sliding? Sliding, okay. The one on the right? It's a still image, right? I mean, that's just a trick. That's just not fair. But, okay, now it's playing, and you can see it's kind of moving. And sliding or not sliding? It's not sliding, okay? That does not confirm you have a pneumothorax, okay? And that's a key point. We're going to talk about it more. The absence of lung sliding does not rule in a pneumothorax, but the presence of lung sliding rules out a pneumothorax. So seeing lung sliding on that left, at that area you're looking at, and in a normal healthy patient supine, you're looking anteriorly, their trauma, if it's sliding, they don't have a pneumo. Your patient who's had VATS and pleurodesis and whatever else, they've got cancer, they've got loculated pneumothoraces, that kind of stuff's different. But we're talking about your regular patient who's dyspneic. You see lung sliding, you've excluded pneumothorax. The next thing we need to look at is Alines. And Alines are just reverberation artifacts that happen when the ultrasound hits a surface where deep to it is a lot different than superficial to it. So it travels well through skin, it hits the pleural line, and underneath is air, and it bounces back to the probe. So that sound wave comes down and comes from the skin, from the transducer, hits the pleura, bounces back, hits this probe, hits the pleura, bounces back, and it just reverberates. It bounces back and forth between those two. Now the machine is simple, and the machine interprets time of returning signal as depth. So each returning signal comes out like that from the ultrasound machine. Okay, so what Alines tell you, and you'll see the distance between the skin and that pleural line is the same as the distance between each one of those Alines. All right, so what that tells you is that what's deep to the pleura is air, or really mostly air. All right, and you'll see it'll move, it'll slide, so that's good. All right, same thing here. Do you guys see the Alines? We're only looking for three things today when we're talking about the chest: pleural sliding or lung sliding, Alines, and B-lines, which we'll get to next. So it's pretty straightforward stuff. You guys see both of those A-lines underneath, right? All right, curved probe. Sliding or no sliding? Sliding. It's not as easy to see, but you'll get used to it. It's nice to use a curved probe sometimes because maybe you're using it for the FAST exam. You don't want to switch over and have to use a linear probe. But there's sliding. A-lines or no A-lines? A-lines. It's easy stuff, right? All right, so A-lines. Air deep to the pleura. That's either normal lung, right? Maybe they're dyspneic because they're anemic. Okay, or it's COPD or asthma, where the lung tissue is fine, or maybe it's even more air than usual because they've got bullous disease. Or it's a PE, right? Think about a clear chest x-ray in a hypoxic patient off a plane with a swollen leg. Okay, pneumothorax is going to look like that. It'll have A-lines, but it won't slide. We'll get into that. All right, that's what A-lines tell you. So take home point number one, sliding, A-lines, the lungs are clear. It's the same as a clear chest x-ray to you.
Hold on, I gotta butt in here for a minute. Everywhere I go, everything I do, anytime someone talks about lung ultrasound, they throw this A-line mumbo jumbo at me. Why? Why do I need to know what an A-line is? It doesn't really diagnose anything, does it? Well, this question's been in the back of my mind for a long time, so finally I had the opportunity, and I asked Lord Bundle himself.
All right, Mike, thanks for joining us. I got a couple questions for you from your lung ultrasound talk that you gave in ASAP. For those of you listening, this is Mike's second time recording these questions because the first time was just so terrible. He was incapable of answering things appropriately, so we had to redo it.
Now, Mike, we've been working on your honesty. Do you want to tell the listeners really why we're doing it again?
All right, so maybe I kind of forgot to record it, but no matter. Now we've got some practice, and we're gonna get straight to the nitty gritty. So, okay. Mike, first question for you today is about A-lines. So one thing that kind of always bugged me about A-lines is that I never really know what to do with them. You know, I see them, and everybody tells me to look for them, but then when I see them, I'm like, well, that doesn't really tell me anything. So what's with the A-lines?
So A-lines are important. They're not maybe as impressive as B-lines when you see them, and they can be seen in normal lungs, so people kind of think, well, I don't need to pay much attention to them because they're normal. But all A-lines tell you is that there is air or mostly air deep to the pleural line. So there's either what Lichtenstein would call pure air or a pneumothorax. So a pneumothorax will give you A-lines without sliding. Or there's mostly air, which is just an inflated lung, with sliding, which will give you A-lines and sliding. So if you have an acutely dyspneic patient who's breathless in your ED, you're evaluating them, you have pleural sliding on both sides and A-lines on both sides in multiple lung windows, that patient has most likely COPD, asthma, a pulmonary embolism, or a non-cardiogenic pulmonary cause of dyspnea like anemia or acidosis or anxiety or something else. So I think it knocks a lot of things off the list. You see bilateral A-lines and pleural sliding, not have acute decompensated heart failure with pulmonary edema, and it definitely steers you in a direction. So it's not quite as satisfying as seeing bilateral dense B-lines with sliding, which lets you know this is going to be pulmonary edema and you've made your diagnosis, but it at least puts you into the bronchospasm, PE, non-pulmonary causes, and steers you a little bit.
So you're using it less as a diagnostic criteria and more as sort of a rule-out criteria. So the fact that I see A-lines and sliding means that it's not pulmonary edema, or it's not, pneumonia.
Very unlikely to be pulmonary edema. And if you had a patient who had a history of COPD, a history of CHF, comes in acutely breathless, is wheezing bilaterally, that's a common presentation we see in the emergency department. If you see bilateral B-line pattern, you definitely treat that as pulmonary edema, whereas a bilateral A-line pattern with sliding, you're going to go down the steroids and bronchodilators pathway instead.
Gotcha.
Keeping in your mind that it could still be pulmonary embolism, there's other causes, but at least that branch point is pretty useful, I find.
Awesome. Thanks, Mike.
Except it took you 3 seconds to do it instead of waiting for the tech. Now, does that look like A-lines? No, there's these bright hyperechoic things that are coming down off the pleura, moving with respiration, erasing A-lines, and going all the way off the screen. Those are B-lines. So how do you define a B-line? It has to be hyperechoic. It has to be bright. It has to start at the pleural line. It can't start superficial to the pleura. That's gas in the soft tissue. It has to start at the pleural line. It needs to move with respiration, and it needs to go off the screen without fading. And you'll see a lot of people talk about, oh, the depth has to be 18 centimeters or 16 centimeters from this study or that study about how the B-line had to go all the way off without fading. It needs to go far enough off to erase the A-lines, right? I wouldn't get hung up on depth. That thing needs to go off the screen without fading. If you're convinced that that's what's happening, you've got enough depth to call it a B-line. And it has to erase the A-lines. Now, I put an asterisk there because some of the lung sonography experts will say, you can't have an A-line pattern and a B-line pattern. It's got to be just one or the other. You'll see times where it kind of looks like there's both, in which case you pick the one you think it more is, okay? So everybody sees that. Coming down from the pleural line, erasing A-lines, moving with respiration, they're hyperechoic, they go off the screen. What about this? Sliding or no sliding? Do you see any B-lines? Now we see this thing, right? It's bright, it comes off the pleura, it moves with respiration. It doesn't erase A-lines. There's not really a lot of depth here, but there's the first A-line. And it doesn't go off the screen. That's a comet tail artifact. All right? And some people feel like, okay, that tells you there's no pneumothorax, but you don't need that to tell there's no pneumothorax. There's sliding. Okay, that's not a B-line. Don't be faked out by it. Likewise, what's that? Is it deep to the ribs? It's not, right? Here's rib and here's rib, and the pleural line should be here. You guys have seen enough to know it should be down here. That's subcutaneous emphysema. It's a limitation of lung sonography, right? That air is going to scatter the beam. You're going to have a hard time seeing the pleural line. Most of the time when you have enough subcu emphysema, you kind of know what's going on in the lung. But it certainly could be like pneumomediastinum without a pneumothorax. But bright stuff doesn't always equal B-lines. You want to see them moving back and forth off the screen, really convincing, okay? What do B-lines tell you? They tell you that there's thickening or fluid in the alveoli or in the interstitium. All right, that's a broad differential of stuff. That could be pulmonary edema, especially if it's bilateral and diffuse B-lines everywhere. That could be lung contusion if it's focal in a trauma patient. You've got some fluid in the lung. Pneumonia can look like that. ARDS can look like that. Pulmonary fibrosis, any kind of thickening of the lung, thickening of the interstitium. All right, that is not the same as an A-line pattern. All of those things look bright white on X-ray when you get an X-ray. Right? So take home point number 2. Sliding with B-lines, there's a linear probe example. You can see they're smaller, but they go all the way up the screen. You do get a sense there is a little bit of an A-line here, but it's a predominantly B-line pattern. Right? That should make you think there's going to be a radio opacity on your chest X-ray. All right, so just to review the technique, and we'll get into individual clinical scenarios. Number 1, get your images. So pick your transducer. I prefer a low frequency transducer like a curve probe if you have it. If not, you can use what else you have. Scanning windows are going to be anterior and posterior lateral, looking for A-line or B-line and sliding anteriorly, looking for pleural fluid and consolidations posterior laterally. We'll get into those. You want to scan by finding a nice perpendicular view where you've got rib, and pleural line, and you want to stop and wait and see what you see. Interpret your findings. Is there sliding is question number 1. Are A-lines present is question number 2. Are B-lines present is question number 3. All right? With just that amount of knowledge, you're going to be able to sort out upwards of 90% of your dyspneic patients in about 30 seconds at the bedside. Now, a lot of them you can sort out without doing lung ultrasound, right? I get a 19-year-old woman with a history of asthma who comes in feeling like it's her asthma and she ran out of her inhalers and has a runny nose. I'm not grabbing the lung ultrasound to bring in and take a look at her. I have colleagues who might, but I'm not going to, right? I mean, we're trying to make this fast and easy, and if it's not going to help us clinically, it's not worthwhile. But all of you, all of us, see undifferentiated dyspneic patients, and this makes a huge difference in their care.
Awesome. Thanks, Mike. So second question for you, Mike. In your presentation, you make sort of a big deal about how seeing sliding rules out a pneumothorax in that particular location that you're looking. But you tell us that not seeing sliding doesn't really rule in a pneumo. So there's other things that can prevent you from seeing sliding in normal lung, or I guess rather abnormal lung, like previous surgery, scarring, things like this. One question that I've gotten a good bit through the podcast and from people that I've just been educating is about pleural blebs. And there's been some concern, I know in the literature, there's been a couple of case reports about how the possibility of large pleural blebs preventing you from seeing sliding. And I wonder, is that something that you can speak to? Should we expect that patients with big blebs are going to have no sliding? I don't want to put a chest tube in a bleb, so how do I avoid that?
So I think this is as yet definitively unproven. There are publications going both ways, where people reporting false positive pneumothoraces based on blebs, and then there are publications where people are reporting they were able to tell the difference between bleb and pneumothorax in patients where the chest x-ray or other imaging was less clear. So there's people espousing ultrasound for distinguishing COPD bleb from so bullous emphysema from pneumothorax, and there's people saying that maybe they could be confused. In my experience, people with bullous emphysema still slide. They definitely have less impressive sliding. It's a little bit harder to see it. It's more subtle. I think we should expect them to slide. I think the whole idea of sliding excludes pneumothorax is really the heart of this exam. This is, as much as it's fun to identify a pneumothorax and act on it by ultrasound, it's much more common to identify sliding and prevent a chest tube than it is to identify absence of sliding in a truly unstable patient where you can't get confirmatory imaging and you can't tell. So, because you're evaluating these patients, they have known emphysema. If they're crashing on you and one side of their chest has no sliding and the other side has sliding, I think that'd be enough for me in the right circumstance to go ahead and put a chest tube in. And the case at the beginning of the talk that I mentioned was kind of like that. But most of the time, you're going to be able to get confirmatory imaging, and if there's a COPD and the sliding is plus or minus and they're stable, I'd be concerned about bleb, having never seen a case personally where a patient with bullous emphysema. So my own personal experience is that patients with COPD and bullous emphysema slide, but I've definitely seen reports, people publishing otherwise.
Yeah, I've got to agree. I've never had a case of someone with bullous disease not have sliding because of that bullous disease, at least. So
at least one of those papers was older machines too, like a good 5 years plus older, where maybe the resolution wasn't quite as good, and it might have been harder to tell if sliding was diminished but not absent.
Right. So you go look for the lung point. If you don't see a lung point and you don't see sliding, then maybe we should be considering the possibility of bullous disease. But who knows?
Yeah, and I mean the same way, 18-year-old otherwise healthy motor vehicle collision, not intubated yet, but about to be intubated because maybe their DCS is low, and they're in shock, and they have absent sliding on one side and normal sliding on the other side. Even if I don't find a lung point, the odds that that patient with absent sliding and an A-line profile, so it's not a lung contusion and a dense lung, but absent sliding with A-lines in an otherwise healthy person who's got no scars from their pleurodesis or whatever else, and they're an otherwise healthy teenager, even if you don't find a lung point, that's a pneumothorax. right? It's really hard to imagine another scenario where that would hold
Right.
true.
Right.
But somebody with COPD, with bulla as concern, I'd be much more inclined to find a lung point before I wanted to put a tube into the chest.
Gotcha. Awesome.
So we just talked about a lot of stuff. Let's hash this out real quick. We learned about 3 lines: the pleural line, A-lines, and B-lines. So the pleural line should be visualized over the anterior and superior chest wall in a supine patient. The presence of pleural sliding basically rules out pneumothorax at that location in the chest wall. Next, the A-line. The A-line is a horizontal line created by reverberation between the probe and the pleural line and should be horizontal and equidistant from one another. The A-line doesn't really tell us a lot other than it's normal to see A-lines. Finally, B-lines. B-lines are longitudinal lines that arise from the pleural line, run to the bottom and off of the screen, and obliterate A-lines in their wake. B-lines tell us there's fluid in the interstitium. All right, so there's our summary. Stay tuned, everybody, for next week's podcast when Lord Bundle comes back to get deep into the clinical scenarios associated with lung ultrasound.
Haney, chill, dude. We promise we're going to have the rest of this for you very soon. In the meantime, go register for Castlefest and work on your jousting. If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.